Welcome back, everyone. I'm Sharon Hennessey, a physiotherapist and advocate for individuals with HSD and HEDS, and I'm honoured to chair session 5 on exploring movement and exercise participation from fundamentals to sports and the performing arts. Ding, ding, ding. Okay. We will start the session with a didactic presentation where I'll address the role of physical activity in managing these conditions, looking at muscle rehabilitation and strength, how to manage stiffness and much more. Following this, we'll welcome our panel of experts to the stage. Well, here are our panel of experts already on the stage. Anita Crawshaw, do you guys just want to wave as I say your name? Anita Crawshaw, Maria Yee,
wave.
Elizabeth Hornsby, Jason Lamb, Anu Francis. Okay. During the panel discussion, we'll touch on a number of topics such as building resilience, how to get started in activities, motor control, dance, and different challenges and success stories in managing EDS in athletics. Each of my panel members will come up and give a short presentation, and then there'll be time for questions at the end. I encourage you to share your thoughts during the panel discussion. At this stage, Slido is still having some technical difficulties due to a global outage. You can still ask questions on the app, okay? If it suddenly starts working in the middle, that'll be great. Otherwise, we'll just be doing raising of hands. Okay. All right. So, what barriers... Oh, is it working? No. It's working, okay. What barriers stop or limit individuals with EDS, HSD from participating in movement, activity or exercise? So can you put up the first Slido, please? Slido is up. Where is it though? Okay, it's working. So just have a think of this as what are the elephants in the room? I think it's all well and good for us to have a session about activity and exercise and how great it is, but what's actually stopping people participating? Pain, yes. Fatigue, dislocation, scared of pain, we'll be talking about that. Fear of instability, absolutely. Stigma, yes. Time restraints, accessibility, absolutely. So I'm happy for the Slido to keep running, but can I go back to my talk or... Okay, so these are some of the elephants in the room that I came up with. So there's your elephant and there's your zebra. So some of the things are important are kinesiophobia, which is a fear of injury and a fear of movement that you might injure yourself, which is very common. Of course, pain, fatigue, lack of guidance, and frustration with slow progress. Other reasons could be exercise-induced pain or symptoms, misconceptions about exercise, negative past experiences, anxiety, difficulty finding the time for enjoyable activities when there's not enough spoons, POTS or dysautonomia, financial constraints is a big one, social and environmental barriers, and of course, the body image or confidence issues. So I'm going to focus on those first half, and hopefully by the end, you've made friend with your elephant. So this is just a little bit of something I've pulled out from our Not Just Bendy new patient intake questionnaire. So out of 636 clients, we asked everyone if I'm afraid that I might injure myself if I exercise. At 82% reported high levels of fear in that they agreed or strongly agreed. So they're the ones in the blue. And then we also asked the question of pain always means that I have injured my body. And 80% disagreed with that. So I think sometimes there's a perception of pain with hypermobility that if everyone just understood that pain's just in your head, then it would be fine and you could just do it. But I think this just really demonstrates that most people with hypermobility or EDS actually understand the basics of pain neuroscience, that pain does not necessarily equal tissue injury, but that still doesn't stop them being scared. So I just wanted to acknowledge that before we go forward. So then we get into a bit of a barrier cycle. So we go from injury to fear of movement, which leads to less activity, which leads to more deconditioning, which leads to more pain, fatigue and disability, and then injury again, and it goes round and round in circles. So how do we start to break that cycle? And we can break it at any point, and I think that's the amazing part of all the talks we've heard so far, is there's so many places and people and professions who can start you on the way to breaking that cycle. So we need people to be validated, we need lots of education, we need to trust our experts, we need holistic support and bravery and persistence, because it is a long-term thing that you've got to do. It's not going to change quickly. Okay, so I thought I'd just quickly review what I could find in the literature about exercise in this population. There's not a lot yet. We're still working on that. People with hypermobility can strengthen at similar rates to those without it, but it takes longer for them to reach a baseline level of strength that you would associate with the general population. So it took 3 to 4 months for the hypermobility syndrome clients to reach the baseline of general people who just had osteoarthritis. So that starting point can be really hard, because until you're at the general strength of the rest of the population, it's going to be hard to access mainstream exercise supports. Delayed onset muscle soreness, so that's your DOMS, is higher in people with symptomatic hypermobility and lasts longer. Tendon and muscle properties can improve with heavy resistance training and classical EDS. Joint hypermobility is linked to impaired transversus abdominis contraction, which is the good old core muscle. Pilates may reduce fatigue, improve strength and quality of life in children. Spinal stabilisation exercises improve pain, balance and endurance. And both general and targeted strengthening can reduce pain. Okay, so what do we see clinically? Okay, so muscles reinforce the passive joint structures, so the ligaments, and provide dynamic stability for the joints. But active muscle holding, you could call it co-contracting, gripping, stiffness, or some people might even interpret it as increased tone at rest, increases pain and joint stiffness, muscle fatigue, joint compression loading, energy expenditure, and the feeling of joint malalignment, and even subluxation and dislocation. So rehab's a fine balance between the muscle strengthening and the muscle relaxation. So if you have a little bit of a look at how I approach things, think of it a bit like a seesaw. We need to upregulate your muscle strength, control and stability, absolutely, but we have to downregulate that joint muscle stiffness and holding. So just to sort of confirm what I'm talking about there with the muscle stiffness or the co-contraction, if you have a joint and you look at, say, your knee, if the passive structures like your ligaments don't feel like they're doing a good enough job to keep your knee in a position of good alignment and tracking, then the muscles on the back of the leg and the front of the leg and the calf and the toe and the hip will all come on together to try to control you. And it's often that gripping of everything, trying to hold yourself together, that can lead to some of the pain where another cause can't be identified, okay? So we're going to talk about these two sides of the seesaw. So we're going to look at that too much, sorry, I just looked at the timer and it freaked me out a little bit. Okay. I don't know how we're up to 22, oh no, it's counting down. Oh, that's good. I thought I'd done 22 minutes already. I'm like, Jesus Christ. Okay. I mean, I know I'm good at talking, but I didn't think I was that good. Okay. Okay, so too much of the upregulation, you'll get stronger, but you'll also get stiffer, and you'll flare up, and then you'll probably give up. Too much of the downregulation means you're more likely to injure because you're going to be too loosey-goosey unless you find a way to put the right muscles underneath the muscles that aren't supposed to be working, okay? So, and just to go back to that a little bit clearly, no muscle activation is wrong, but we want to try to find the most efficient way of doing things. So we're going to talk about the stiffness and the gripping side first, and we're going to talk about stretching. It's a very common question I get asked. Should hypermobile people stretch? And some people have been told by health professionals not to stretch, okay? And I think the problem with that is it's not acknowledging the fact that as a hypermobile, you feel extremely stiff the entire time, despite being extremely hypermobile, okay? So stiffness, again, that's the co-contraction of those muscles. So stretching alone is unlikely to deal with the underlying cause. But stretching can relieve muscle tension if properly targeted. So using modified stretching and taking it slow to make sure you're stretching the muscle but not putting pressure on the joints or ligaments is a really important thing to do. And you want to always consider your posture and the positions of other joints during the stretch. So if you have a quick look here, a lot of people come in and say, I'll do a quad stretch. And they go, I can never feel a stretch in my quads. And they're often doing this. So you can see here, although you can't feel it when you're doing it, that by adding a big back arch and pulling the leg back, that changes the length of the position of the muscle. Once we correct those positions, this person is actually quite stiff, okay? So it's just making sure that if you're not feeling a stretch, you just don't keep getting stretchier and stretchier and stretchier. You have to come back and look at the posture and alignment to make sure you're in the right position for that stretch to occur. So when to be cautious with stretching? So you want to avoid excessive or deep stretching without addressing your stability, and discourage the use of external overpressure. So that's other people pushing you into stretches. Try to control it yourself. Yoga, okay, has many benefits from a mental health point of view, but you do need to be cautious with the deep, prolonged stretching, and modification is often needed. So there's different types of yoga. Some are very deep stretchy, some are more about control, and it matters about how important it is for your mental health that you keep doing it, but also that you have enough other things in your program to offset that. Okay, so what's some other ways to deal with stiffness, particularly if stretching is only going to be subtly helpful? So things like learning to just let it go. We all love the song. I won't sing it. You're very lucky. But I suspect that some of you here are perhaps, I always say to my clients, I feel like even when you're asleep, you're hovering about 5 mils off the bed with tension. So it's that feeling of actually just letting your brain know that it's actually okay, you're not in danger, and you can let that tension go. Breath control can really help with that. Trigger balls, I'm sure everyone's rolled on a trigger ball at times, and foam rollers can be good, but you just have to watch what position the rest of your body is when you're trying to sort of squeeze over the side of a foam roller, okay? You can get little like suction cups, you can get them on eBay, they're good for self-massage. Some external devices like a massager can be good. You have to just watch how much release you can take. That's why I like the Dr. Graham, because it's a more of a gentle release rather than a Theragun intensity. Not that some people might love their Theragun, but not everyone's going to. Contract relax is when you contract a very tense muscle and then you let it go, and you get this inhibition of the muscle when you let go. So, they can be quite helpful. Your stretches, and then of course accessing whoever's on your team to help with the tension. So that's your mobilisations, your massages, your needling, all those sorts of things can be very helpful. Other things that we can do to help reduce stiffness when we look at the body as a whole is to put more of the good things into it, okay? So finding a posture that doesn't hang can be a really good start. We're going to be talking about that a bit more tomorrow in the cervical spine workshop, okay? Dynamic taping, if you're not allergic. There are a couple of brands, Dynamic Tape and Sensitive Rock Tape seem to be better, and you can get skin prep spray to put on underneath. It does help. Still not enough for me to be taped, but for a lot of people it does. You can see in this picture here, we've got someone with a dislocated shoulder at rest. Can you see that? That's their shoulder down there. And then that's with their tape on. Body braids are extremely useful because they're elasticated, so still allow you to continue to move. Things like compression garments can be very helpful. Controlling the positions and the load across the joint. So perhaps cushioning might be helpful. So finding a nice cushion to sit on. You can go have a look at the website for Therapeutic Pillow. They have a lot of really quality bed and seating alternatives. Pacing, very important. I'm sure you've heard that 1,000 times. Okay, so now we're on the other side of the seesaw. So that's sort of more how to manage the pain that crops up that you're going to get from exercising, because you have to deal with that or you're not going to want to go back. So then when we start looking at muscle rehabilitation, look at it, there's lots of different components, and I think that's the part that's hard, right? Because you end up with about 1,000 exercises, which I know is pretty overwhelming. But you can sort of, the way I like to group it is to sort of think about the joint stability, the motor control and the strength, and then looking at how we can add in cardiovascular and proprioception, so that's your balance and your joint feel. I'm going to focus on the 3 big cogs there that all interconnect. So if we're thinking about joint stabilising muscles, these are the smaller, deep muscles that are able to provide an active stability to the muscle or the joint control. So it's about considering at a joint level what muscles you need to deeply scaffold the joint. So say a shoulder is popping out the back, we need to work out how to activate the muscle at the back to reinforce that position, okay? You want to retrain the muscle in a simplified manner, in a supported positions with neutral posture. Isometrics mean just contracting it rather than moving it and contracting it. Isolated and slow. You guys hate moving slowly. Have you noticed that? Oh my God. It's a run or a crash. So we work on the slow, mindful movement. And then you can use some other devices, like sometimes we can use a real-time ultrasound to visualize it, or we can put a muscle stimulator on. And what turns on must turn off. It's no good if you've got the best, strongest pelvic floor in the world, but you can never let it go, okay? So we have to learn to turn it on and turn it off again. Motor control and efficiency. So this is more about analysing how the body moves through common positions, such as standing, squatting, walking, squatting, or doing some sport. And then we're looking to see if there's any way we can improve the efficiency of that movement and improve quality and control. Because as we collect injuries, we start to move differently, and then we don't want to go back to the other way because we're not sure if that's what hurt us in the first place. So we want to place the body back into its functional pattern, and that's looking at, we're not just going to look at your toe, we're going to look at you all the way up the body, okay? Be aware of other joints, use visual and tactile feedback, and be very particular and be monitored closely. And then the muscle strength, I think, is more what we think of when we think of getting strong. So this to me is more your functional exercise with graduated loading, such as a gym-based program or a weights-based program. But for us, for hypermobiles, you need to look at progressing slowly with your reps, or progressing your weight, or progressing the posture, or adding a balance challenge. What I see a lot is people start to feel good and then go, oh, I didn't injure myself, I'm going to do twice as much tomorrow. And then the next time they don't injure themselves and they do twice as much again, and then they fall in a hole. So you still have to pace it up and just be very gentle in that progression, keep maintaining your form and stability, and you can only progress as fast as your weakest area, and be prepared for flare-ups, and which area is the weakest one will generally change as you do more exercise. So I'll just do a quick case study just to give you a bit of an idea how this comes in for a single client. So in this case study, we're looking at someone who presented with lots of different pelvic types of pains that if they had scans, they probably would have had a hip bursitis and a low back disc injury and blah, 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 blah. But that doesn't help me what's on a scan get you better, okay? So I look at what your overall pattern of movement is. And so you can see here, I've put the lines on, that this is not an ideal way to stand on one leg, okay? Because we're leaning over to the left. And then on this leg, the patient is dropping down and having a Trendelenburg and putting pressure here. So then when we looked at yes, they were diagnosed as generalised HSD. Then when we looked at the 4-month follow-up, these are the same patterns under here, okay? So you can see their spontaneous one-leg postures, much improved with the alignment in the back and the pelvis, and the squat is not perfect, but we're definitely on the way to a much better angle there. And then In this case, we needed to also have hands-on therapy. They had an external provider doing that. We also had to see a women's health. They also had to see a women's health physio, okay, because they had pelvic floor issues going on. So, yay, great. Who cares if you can stand on one leg, right? But there's a reason why we harp on about it. So this might be a bit hard to see, but these are basically some of the subjective measures that have changed from the beginning to at the 9-month follow-up. So the patient had rated themselves as very much better, but when we look at that annoying visual analog scale of pain, their worst pain had only gone from 5 to 4, and the frequency had only gone from 50% to 30%. So if you're only looking at that, you might think, oh, this is useless. But here, if we looked at the activities that they're doing, at the initial, their problems were driving a car and lying on their side. And at 9 months follow-up, their problems were bike riding 30 kilometres and lifting a barbell from the floor. Okay, so I know often, and their ability to cope with their pain in most situations had gone from an inability to cope to able to cope with pain in most situations. So just try to remember that when you have a flare, it might feel like you're back to where you started, but it's probably just a little dip on the way, okay? And because it's hard to, it's easy to remember how much pain hurts, but it's hard to remember what you were doing before when pain used to hurt, okay? So another common question we get is, how do you know when you're exercising if you've hurt yourself, if you should keep going to the gym, or if you should stop because you've injured yourself? Now, this is a question you'll have to start listening to your bodies and tuning into them instead of blocking them, which I know is hard. But if you get a large pain flare or a new injury or a new instability or a partial dislocation, and you've got a lack of joint motion, that's when I'd say you need to stop and seek help from your professionals. As a yellow light, think of if you've got pain or niggles that don't quite settle down until the next session. Now, how long that next session is different for the individual. Some people it might be 24 hours, or some people it might be 72 hours. So it's hard at those first couple of days to know what's a DOMS, what's a flare, what's an injury, and what's the flu, right? Because the pain's all sort of mixed together. But as you get used to your own pattern, you'll start to work out how long that usually takes to settle back down. Green, continual progress, any pain or niggles settle to baseline before the next session. So I think you need to find, we've had a lot about all this team stuff, but how do we find a team outside of the people that you've seen sitting on the stage, okay? So I think you need 2 people if you're going to be exercising. They might be the same 2 people, or they might be different people. One's going to be the person who deals with your injury, stiffness side of the scale, okay? And one's the person who's going to help you with your exercise. So you need someone you can trust, so have a look for, it can be a physio, a myo, a chiro, an osteo, acupuncturist, could be a massage therapist. You want to look for someone with experience with hypermobility. If you can't find that, find someone who's got interest in chronic pain, irritable conditions, or rehabilitating or used to treating the elderly, okay? Okay. Because they'll have a better idea of how much they can push you, okay? And they want to be using a gentle, tailored approach, and you have to be free to put your hand up when you're feeling apprehensive about something that's being done, okay? And I know that's hard. I find that hard, and I'm a physio, right? So the second person you need is your exercise progression and supervision professional. So this is just someone who's going to look at you for regular exercise reviews and supervision. So it might be a physio, an EP, or you might have to go into the realms of a personal trainer depending on where you live and what you can afford, okay? So we're looking at the same things. Can they rehab the elderly, do slow stream rehab, gradual tailored plans, and be brave, speak up. I think I said all that. So, apart from looking at the EDS directory, join the Facebook groups, ask your local community who's good, read the profiles on websites, call and speak or email the receptionist to ask them if there's anyone at the practice who takes this type of tricky client. Sometimes practices with Reformer Pilates or practices focused on women's health concerns generally have a better understanding of hypermobility, and of course your online option is the Zebra Club. Now these are things that you can get out of the PDFs which you can actually give the members of your team to help educate them a little bit. And these are the things I sort of say to the trainers. So they have to keep a really close eye on you that you're moving efficiently and that you're not using trick movements, okay? And they need to make sure that the posture and the technique is there the whole time. You want someone who's going to understand that there's going to be chronic injury as well as acute injury, and that they're going to need to change their approach with you on a session-to-session basis, depending on where you are. Pain and injury can take as long as 72 hours to appear after exercise, so be aware of that when you start, about how many times you start going to the gym when you're feeling really enthusiastic. Avoid pushing through pain, fatigue, or apprehension, and that's what I mean above your baseline level, okay? And then you can only progress at the weakest area, okay, we said all that. Exercise recommendations, so you can warm up but use low load activities for the same muscle groups. So say that you're going to go and do a deadlift, then you might start with some squats and bridges on the mat just to start activating everything. So when you go to lift the heavy thing, then all the right muscles will hopefully be turning on. You might want to start with higher rep sets and lower loads, but then as you progress, if your POTS isn't coping, then you could do lower rep sets and higher loads. So it's really dependent on the individual and what works. They need to be aware of your POTS. They need to know that interval, and we'll hear more about this in the POTS workshop, but potentially interval cardio programs with recovery periods are better tolerated, so 60-second intensity of cardio rather than trying to do 20 minutes of cardio, okay? So then you come back down to baseline heart rate and then you do it again, so you cycle through. You don't want to have someone who's getting you down on the ground to do a push-up and then getting up to do star jumps and then down on the ground for a push-up. You need to do all your lying down stuff and your standing stuff in two different sections, so you're not infuriating your POTS from getting on and off the ground the whole time. And you need a cool environment with electrolyte loading before, during and after exercise. And we need to maintain open communication. There's no real room for egos in these teams. We just want all focus on client outcome. So always remember the Goldilocks principle. Oops, we've forgotten it already. Okay, so it's not too little, not too much. We want to find the just right amount. Okay, so you don't want to move too fast or too slow. You don't want to move too little or too much. Muscles we don't want them really weak, but we don't want them really stiff. We want to be understanding how we're feeling and not catastrophizing about it. We want joint protection, but not fear of movement. And we want to not be black or white, but find the grey. Has anyone found the grey yet? Anyone? Yay, someone found it. Okay, great. Okay, so in summary, the path is going to seem overwhelming and you can only choose the right path for you at the time. There's a lot of roadworks needed on that road you're travelling. Frequent stop and changes are likely. Just pushing through on a broken road isn't going to be the best long-term solution. Having a team will help you stay out of any big holes or prevent you falling in, okay? Or prevent you falling as far, let's put it that way. And it might be 2 steps forward and 1 back, but if you stay consistent in the long term, you will see improvements. Okay, so here's my elephant in the room, and look, he's in love with the zebra now. And here's some pictures of me being absolutely terrified to move, but I actually had a really good time after I got over the fear. So courage is not the absence of fear, but the ability to live with it and to still move forward. Thank you. Okay, so now to move on to our panel speakers, which I have already briefly introduced. They're going to give a little bit of an introduction to themselves as they come through. So the first person I'd like to bring up is Dr. Elizabeth Hornsby, who's a physiotherapist and director of Kids Care Physiotherapy and has also done her PhD in hypermobile kids. I don't think the Slido's working, but just start having a think if there's any activities that you would think that we would not recommend for a hypermobile person to do. Okay.
Thank you for that introduction. Now I'll let you know what the answer is at the end of my talk, so remind me if I forget. Oh. Okay, they're coming in quickly, so we'll do it now. Anyway, the answer is nothing is off limits, it just depends on the individual. Okay, so I'm going to talk on how to get started with participation in activity. Now, what we need to know are, what are the guidelines? What are we expected to do? Now, Australia has physical activity and sedentary behaviour guidelines, where for adults they should accumulate 2.5 to 5 hours of moderate intensity exercise per week, and children should be at least 1 hour of moderate to vigorous physical activity daily. And you should include muscle strengthening, adults at least twice a week and children at least 3 times a week. But with children, it's more aerobic, weight-bearing exercise like sport. That's using the body weight, not lifting weights. So that's a bit scary for most people. Actually, 30% of your average kid does not meet those guidelines in this day and age, which is a little bit scary. But the key points are doing any activity is better than doing none. Be active on most days. Try and minimise prolonged sitting. Minimise the screen time to less than 2 hours a day for children. That's recreational, not school. And guidelines for sleep. Primary school, 9 to 11 hours per night, and high school, 8 to 10 hours per night. And that will feed into your fatigue. If they're not getting that amount of sleep, that's the first thing that's going to affect fatigue. Okay, we've already seen at the first slide all the common symptoms that are barriers to participation, but the main ones as exercise therapists, we're looking at the chronic musculoskeletal pain, reduced muscle strength and joint stability, reduced proprioception, reduced motor coordination and greater general fatigue. And all these can lead to reduced physical activity, endurance, function and your ultimate quality of life. So how to get started with physical activity? Low impact exercise is recommended initially if you're symptomatic. With pain, swimming, walking, Pilates was reported to be the most helpful exercise modes in a big study by Jane Simmons in the UK of over 1,000 adults. And then once you've started exercising, then you can progress to higher impact exercise as your body allows. So nothing's off limits. It really depends on your body and how you're coping with it and if you do it gradually. So when you're getting started, sometimes individually prescribed exercise, initially from a health professional to avoid exacerbation of pain. And goal setting is really important to help change our behaviour of physical activity. Okay, there's lots of different ways of setting goals, but the SMART framework is a common one that we all use. And the acronym stands for, the S stands for, the goal needs to be specific and clearly defined. So for example, it might be improving your walking speed over 1 kilometre to improve your fitness. It needs to be measurable. You choose goals you can measure to track progress, like the 6-minute walk test. They need to be achievable and realistic. Don't start with, I want to do the next marathon. Okay, it might be, I want to be able to walk 1 kilometre around the park without feeling any pain. The goals need to be relevant. They should align with your priorities. Like I want to be able to walk faster and improve my cardiovascular fitness. And they need to be timely. You need to define a time frame to maintain your focus and urgency, such as at least 6 weeks. It might even be longer. And it's okay if you don't reach your goal. You've made progress. You can just reset for the next period. So exercise management approach to hypermobility disorders. I mean, exercise prescribed by Allied Health in the research is said to play a central role in the management of adults and children with hypermobility and pain, and everyone talks about it. But then when I did research, I looked up and there are only 2 clinical trials in children on exercise. So I was currently doing some Pilates with children and I'd noticed the benefits. So there was absolutely nothing on Pilates in children in this sphere. So that started my research journey and doing my PhD. So the aim of an exercise program is to decrease pain, improve your postural control and balance, improve your strength and motor function, reduce your fatigue, and improve your quality of life. Now, the ICF framework, it's a framework allied health medical professionals often use, and what it means is it's a framework we use to look at the whole person, because health professionals are very good at looking at the body structure and function, pain, range of motion, strength, all those sort of things, and this helps us to look at how's it affecting the person's activity in everyday life, how they're participating in sport and things, and to think about the impact of the environmental and the personal factors for that person. So I'm just going to really briefly talk about an aspect of my study. I'm going to use one of the participants as a case study. It's in the paper's in the resources if anyone wants to read it in more detail. So from the characteristics of this was a young girl, 8 years of age, who was diagnosed with paediatric generalised hypermobility spectrum disorder. She had chronic pain in her right hip and knee for most days in the past 6 months, particularly when the days she was active. She was quite active. She played soccer a few times a week and was doing swimming, and her Baton score was 6 out of 9. Now, the Pilates intervention was a individualised format. It was mat and reformer Pilates exercises, which all the kids enjoyed. And the dose was 8 weeks, 2 by 45-minute sessions a week, plus a home program once a week. And what I did is I tried to, it's important to measure the progress with good outcome measures, and I tried to measure them over different areas of the ICF. So I looked at pain, muscle strength, fatigue, dynamic posture and balance, activity levels, and quality of life. Now, everyone always wants to know the results. Let me very quickly talk about the type of study I did. Most people are familiar with an RCT or a randomised controlled trial, and that's where you have outcome measures. You measure the participant before the intervention, you do the intervention, and then you measure it after the intervention. And normally you have a large number of participants, and then you get the average to see whether the intervention helped. They were significantly improved. Now, what I did was the SCET, which is a single case experimental design, because it was a very intensive program. There were no other paediatric physios who did Pilates in my area, so I had to do all the intervention myself. So what I did is I had 3 participants, and you do the measures, they each act as their own control, and you do the measures weekly for 20 weeks. So that way, in a sense, the results that I'll quickly go through weren't as good as I hoped, but it did give us a lot of information because no one had ever measured pain in these kids before. And if you look at the graphs, so the results were there was improved strength, significantly improved strength in some muscles. And if you look at the top graph, how you analyse a SCED study is that the vertical green lines, they're showing you the different phases. So the baseline phase is where there's no treatment and just measuring them weekly. Then you have your intervention phase for 8 weeks where they did all their Pilates, and then you have a withdrawal phase where you sort of expect to see the improvement in the intervention phase and then it to drop off in your withdrawal phase. And so you need at least 2 points above that upper 2 standard deviation line to see significant improvement. So in that graph, there were heaps of graphs. In that graph, that's a significant improvement because you can see in the intervention phase, halfway through the intervention, you could see the improvement. But what surprised us that even through the withdrawal phase, it continued to improve. So that showed there's a lag from when the muscle strength really starts kicking in, and it still stays there after the intervention because the child or adult has become more active and they're using those muscles more. We saw reduced fatigue in both in the intervention phase, and then when the Pilates intervention stopped, it started to increase again, which was what we expected. We saw reduced pain. So in a lot of the graphs, we saw a trend. Like if you look at the bottom graph for the pain levels, you can see in that intervention phase, the main problem was the pain was so variable all the way through. And you'll all understand that from day to day, week to week, it's totally different. And so it was very hard for us to get to that significant level because their pain was varying so much. But you could definitely see that trend. Towards the end of the intervention, the pain definitely went down and stayed down. So what I learned from that, and what we can all learn for the clinicians out there and for the everyday person trying to exercise, so it's going to take longer. So I recommend extending the Pilates intervention. You're not going to see the improvement quite in 2 months, but do it for at least 4 or 6 months, or whatever exercise program you're going to do. Use more functional outcomes measured. For the strength, I use handheld dynamometer, which can be inconsistent, but the main problem is the kids, if they had pain in that area, they wouldn't push. So it wasn't giving us good results. So use a more functional outcome measure of strength, such as the, you could do the jump test, or you could do lying on your back increased endurance, or the Y balance test. And Jane Simmons has recently done a study in that area, which has been really helpful. I'd record pain levels more frequently. Don't just do it once a week. You could do it every day, and focus on the area that you're treating, that's problematic. Like if it's painful knees, just do the knees, because with the VAS, it was the pain in your whole body, and the kids would trip over or fall off their bikes or doing all these other activities, which was affecting the results. And I also had one little boy who's very hypersensitive, and he was 9 out of 10 all the time, didn't matter what he was doing, but he was improving in reps, improving in resistance of springs and everything. So maybe look at other things, not always focus just on the pain. We need to have a meaningful measure for the participant, something like the goal attainment scale, because I asked all the kids at the end, what change have you seen? And one said, I can run all lunchtime without getting pain. Another one, I can play a whole soccer game without getting pain. And I thought, why didn't I measure that? So it's important to have something that's important to them. So now the other speakers are going to give you insights into participating in activities with higher impact on the body, such as dancing. And I'd just like to introduce Maria Year, who's going to give you a little bit more insight into that. Thank you.
Thank you, Liz. So I'm just going to be talking about dance participation for children and youth with hypermobility disorders, and in particular just share some findings from a recent study that I conducted with my supervisory team at the University of Queensland in Australia. And so before we start, this is not a Slido, but just a show of hands, who in this room has danced before? Yeah. Okay, and who has children with hypermobility disorders who danced or, used to dance? Yeah, and raise your hands if you think dance is good for people with hypermobility disorders, and raise your hands if it's no, and raise your hands if it depends. You can change your answers. Okay, so I think, there you go. All right. So we decided to research dance participation in the hypermobile population because I was starting to see a good number of clients at our clinic who were asking things like, is dance safe for me to do? Or sharing things like, my social circle were my dance friends, and now that I can't dance, I feel so isolated. Or, they're finding it hard to deal with the home exercise program consistently, and they would prefer something more fun. Or they had to stop dancing in their teens because of surgeries or symptoms of hypermobility, but they miss it, they're feeling better, and they want to return to it. Or they want to learn dance as an adult, but they don't really know where to go, and they don't know if teachers understand their conditions. And another person who said, without dance classes as a kid, they probably think they would have been a bit more worse off physically because of the amount of physical activity that she could do. So we interviewed a total of 40 participants across 4 different groups in Australia. So children and young people who dance or used to dance with hypermobility disorders, the parents, healthcare professionals, and dance educators to explore their experiences and perspectives on dance participation. So we will be sharing some preliminary interview results today. It's been quite interesting, also quite wide-ranging, so you're going to get a little brief snapshot today on the more pertinent things I think that are frequently asked, and hopefully that answers some of the questions out there. But feel free to come up later during lunch or after to talk about other findings. So in terms of perceived benefits and challenges of dance participations, what participants nominated, we split into 4 different domains: physical, cognitive, psychological, and social. In terms of physical domains, participants said, it improves my body awareness. I know where my joints are in space a little bit more because my teachers keep yelling at me that my elbows are hyperextended or my knees are hyperextended, and I get, told off each time. And so they develop that control. They develop the strength. It's a way to be active that's really fun for them if they love it, and a way to develop movement competencies. On the downsides, they did bring up, injuries. Obviously, that's a big worry. Managing the fatigue levels, and also worrying about exacerbation of their symptoms. In terms of cognitive benefits, dance obviously has that creative component in there. You get that, memory and attention benefits as well of learning new choreography and learning movement patterns that are quite novel, and also understanding the body's own limits, because you have to push yourself to limits that you might not explore in day-to-day life. And so when to push, when to rest, and all of that sort of physical literacy. In terms of psychological benefits, so a lot of them identified that, they're a dancer. That's the sense of identity. It gives them that sense of belonging, to belong to a studio. It gives them that sense of joy and well-being. Parents are saying that the child's like the most calm, the most peaceful, and the most joyful when they're dancing. And it develops their self-esteem and self-confidence. On the challenging aspects of it, obviously, we do know that dance can be a breeding ground for mental health illnesses if they're not taken care of. Things like anorexia, things like anxiety, a drive for perfectionism, and also participants were talking about a grief over a loss of a normal childhood if they were training as elite dance students. Social benefits, the dance studio as a second family was something that a lot of young people said. They get the opportunity to mentor younger dancers. They get employment opportunities at age 11, 12, 13, as a dance teaching assistant. Parents are saying, they weren't as worried about their child who was struggling in school because they thought that potentially they could be a dance teacher when they grew up because they were excelling in that space. And the downsides to social domains were, some people were saying, they've got a lack of time for other activities, which is quite normal. And I think across other sporting and recreational activities as well, if you're doing something seriously, it's always a bit of a give and take with that. So here are some of the quotes from participants. I'm just going to briefly whiz through them. So Winnie, a parent of an 11-year-old child with EDS, on how she thinks dance has benefited her child. She says it's been really good for her to learn slow movements, how to control her body, understand its limits. And when we've done injuries and we're hesitant to get moving again, it's been really good to get her moving again. She's got a best friend in dance school. She thinks it's because it's a more controlled environment. This as people, this better for autism. And also it's been great for her confidence. She won't get up and speak in front of a class, but she'll get up and dance on a stage at nationals in front of a class, full of ballroom, because ballroom full of people and not bat an eyelid at all. And so she thinks it's really been positive. They've encouraged her and they've helped her to grow. And Jenny, a 16-year-old with hypermobile EDS on employment opportunities. She said she started volunteering for it when she was probably about 11, and then recently this year started getting paid for it. So it's like a proper job, and she's really proud of it. And it's been just really fun. It's been nice to help out at the studio. It's nice to watch some of the young ones that I used to teach like a few years ago, and then going through with them. It's really nice to see them growing. So that's really nice. So is hypermobile beneficial or detrimental for dance participation? It depends, and it depends on a few things. And I'm just going to go through quickly the factors across the 4 different groups that we interviewed. So in terms of dance educators, studio culture is extremely important, and I'll talk about that shortly in the next slide. And the perception and the value and meaning of hypermobility. So do they abuse it? Do they nurture it? Are they scared of it? Do they embrace it? Do they like it? All of that affects how someone will do in the dance studio. And the quality of dance education, where they're trained, how qualified are they? Do they have healthcare professional backgrounds, for example? Have they taken other, Pilates training to supplement their teaching education? Are they old school? Are they new school? There's a big cultural shift now in dance education in Australia, and it's shifting towards a more health-centric approach, which is fantastic. For children and young people, are they dancing at the level that you're capable of? Or are they pushing beyond what they're functionally capable of? Do they have comorbidities like POTS and systemic sorts of comorbidities? How do they view dance? Do they love it so much that they're resilient? What are their psyches like? And how do they view hypermobility? And how do they understand how to take care of the hypermobility and its implications on their body? Do they have access to healthcare professionals who understand them and understand how to work with them? And do they have good relationships with them? And do they have support at home? Which brings me to the parents. So we found that parents who had their own, good understanding of hypermobility disorders, they weren't scared of it, and they were experienced in that sense, were able to pass on their knowledge and confidence to their child. And in terms of healthcare professionals, I think an intricate knowledge of hypermobility disorders and dance is important. Communication skills and rapport with dance studios, parents, and health and young people were important. So to summarize, barriers and facilitators to dance participation. In terms of facilitators, human first, dancer second was the most important thing that came up. A collaborative environment where it's not just a top-down approach, but you have open communication amongst all parties involved. You have teachers who are open and willing to understand more, which was actually valued as more important compared to having an understanding of hypermobility. It was more, if my dance teacher is open to listening to me and seeing me as a person, I did well at the dance studio. Having good referral pathways to access healthcare professionals who were knowledgeable in hypermobility disorders were also facilitators. So in terms of barriers, I think we've gone through that. It's just really the opposite. If you have a studio that emphasizes competitions and a studio that puts students' well-being second, then participants did a bit worse. Having a lack of regulation in terms of dance teacher qualifications was also something that was a barrier. Overvaluing extreme extensions was also something that was highlighted as a barrier. And negative healthcare experiences. Some quotes again, just to whiz through them. So Jackson, 21-year-old with hypermobile EDS, on what he appreciates about his dance teacher. So dance teacher is very understanding of a lot of things. She's got lots of health conditions herself, so she's very good at modifying and changing things to work with the person and not kind of forcing something onto someone when it just doesn't work for their body. I've worked with other dance teachers and choreographers who just aren't like that. They don't really do that, and I found it a lot harder to work in that environment and stay. So it's not positive because it's not collaborative. And Matilda, parent of a 14-year-old child, on what she values about her daughter's dance studio. They take care of the dancer, which is what I wanted. They didn't want them going somewhere where they were made to do something earlier than they were actually physically able to do. And Sarah, on the conflict between her school physio and dance teachers. The physios are really caring. We don't really want you to go off, but we also don't want you to, be like limping like an old lady in 40 years, which was their thing. Catch it early and then time off won't be really long. But the problem with that was that the ballet school and the teachers only really cared about the dance concert coming up. And last one, Laura, who's a dance teacher but also an exercise physiologist, on her experiences in a new dance studio that she was teaching in. When I first walked in, the first lesson, I remember they got the kids on the floor straight into split stretching, and she was like, oh my God, it's taken a long time for me to change the practice over a long time. And I feel like we generally have a good approach. They're very educated on how to safely warm up, how to safely stretch, but they don't have the knowledge of conditions because, again, where would they have learned that? They don't have the access to that information. So to finish off, I think recommendations for safe dance participation with this group of people that we are working with. I think access to healthcare professionals who understand the intricacies of hypermobility disorders and the demand of dance participation for an individualized tailored approach like what Sharon talked about is very important. Understanding the qualifications and training styles of dance educators is important for parents when you're selecting studios, making sure that they align with your goals and your ethos. And fostering a culture of collaboration amongst all the key stakeholders involved for sustainable and safe solutions, because it needs to be very individualized. Everyone's different. And finally, I am also now working towards developing relevant and accessible resources for dance educators to manage children with hypermobility disorders. That's it. Thank you. I would like to hand over to Anita, who will be just going through the physio side of dance participation.
Good morning, everyone. My name is Anita Crawshaw, and I'm the Director of the Hypermobility Clinic in Christchurch, New Zealand. And I will be presenting to you today on the challenges for hypermobile dancers. The ideas I will be sharing with you today have been shaped by two important personal journeys in my life. The first being that I have participated in dance as someone with HEDS. The second being my profession as a hypermobility specialist, having worked closely with many dancers to provide treatment and advice over the last 20 years. As a young girl, my first exposure to dance was ballet, which ignited my interest in many different styles of dance. As an adult, I then developed a passion for social partner dancing, such as salsa and West Coast swing, which I still actively participate in. On screen, we have a few wide-ranging dance forms showing hypermobile joints. Many great dancers are hypermobile, from amateur through to professional ranks. However, hypermobility has a particular set of challenges which require ongoing dedication and effort to manage successfully. For me, my primary hypermobility challenge was unstable ankles, leading to more ankle sprains than I can count as a child. Growing up in a medical household, my ankles were strapped, I was given anti-inflammatories, and we did not realise that these recurrent injuries were unusual. It wasn't until I got to physiotherapy school that I was determined to fix my ankles, and I worked hard on lower leg strength and proprioception. I'm happy to report that I have not had an ankle sprain since then, even in 3-inch heels, spinning rapidly on slippery dance floors. With the right exercises and dedication, it is possible for hypermobile dancers to reduce the risk of injury to the point where they can successfully participate in dance. Each dance form has its own set of foundational skills, which may include a combination of coordination, strength, alignment, balance, and proprioception. The hypermobile dancer may struggle more than normal with any of the aspects just mentioned. A classic example in ballet requires plantar flexion of 180 degrees during point. However, the hypermobile dancer often plantar flexes beyond 180 degrees, as shown on the photo on the left, which creates issues with instability and lack of control in a point position. This increases the likelihood of injury due to incorrect anatomical alignment under load. Another example I see often in my clinic comes from Irish dancing. Irish dancing has an overemphasis on turnout, even more so than ballet. This can lead to instability at the hip and labral tears for hypermobile dancers who have not developed the glute and core strength to cope with this position. Also, quite a risky movement in Irish dancing are the ankle rocks, as shown on screen. In fact, just watching them makes my hypermobile ankles feel very anxious. My last example is from cheerleading. Cheerleading requires explosive force generation from the floor, ballistic strength, and power. A hypermobile cheerleader may struggle to stabilize their joints while generating large explosive forces or when their body is being decelerated during a catch. Hypermobile cheerleaders often hinge at the L4-5 vertebrae during bridges and backwards handsprings. This often leads to the development of chronic low back pain at a young age. Due to time constraints, I'm only able to share these few examples. However, there are many other dance styles with wide-ranging challenges I didn't mention today. Given that hypermobile people have wide variation in their hypermobile joints and unique alignment issues, hypermobile dancers will require specific and tailored specialist advice to allow them to successfully participate in dance injury-free. As I mentioned earlier, each dance style has its own required skill sets. Hypermobile dancers need to invest adequate time and effort into mastering these foundational skills in their chosen dance form. As their risk of injury is always higher, they will have to pay particular respect to their body's unique challenges and limitations. Recurrent injuries or chronic pain are a strong indicator that there may be a biomechanical problem in a movement pattern that they are executing that needs to be addressed. The biomechanical problem could range from a strength imbalance, impaired proprioception, or the most common example being unknowingly taking a joint repeatedly into its hypermobile range, often under load. A good dance teacher or coach will be open-minded to liaising with the dance physiotherapist in assisting the hypermobile dancer to overcome their limitations and accommodate their challenges. Practical advice any hypermobile dancer can take home today is to put more thought into completing specific strength and skill goals before they can safely progress to the next level. These goals can be set in conjunction with the dance teacher, physiotherapist, and family. For example, during a pre-point assessment, one of the objective assessments that needs to be achieved before a ballet dancer is allowed to go on point is between 25 to 32 single leg calf raises to full height with good technique, and that number varies depending on the dance school you're attending. The article on screen is a very interesting systematic review highlighting challenges recreational hypermobile ballet dancers face when compared with professionally trained hypermobile dancers. One interesting finding is that recreational ballet dancers with hypermobile hip external rotation had 1.9 times higher the risk of foot and ankle injuries. I should mention that care must be taken when fitting dance shoes. The hypermobile dancer is more prone to developing injuries such as Morton's neuromas, which can be caused by tight-fitting shoes folding the metatarsal heads into an unnatural position. Note that the X-ray shown on screen is more of an illustration rather than an actual X-ray. The actual fibrosis would not be visible on X-ray. With tight-fitting salsa shoes, I have accidentally given myself a Morton's neuroma, and on another occasion, an intermediate dorsal cutaneous nerve injury. I also competed in a salsa competition with a fractured fifth toe after walking into a coffee table. Not ideal. I have a strong memory as a child of being asked by my friends why I was so coordinated and graceful when I danced, and yet could easily trip while walking across the road, accidentally run into a pole, or fall into a ditch. This is a common experience for hypermobile dancers. And ironically, as you can see on the screen, on the left, that's me. I broke my arm on my 10th birthday, and ironically, I happened to be wearing a zebra sweatshirt. And that was long before I even knew that I had HEDS. So before we move on to Jason's presentation, I have a Slido question for you on screen to ponder. What percentage of a hypermobile person's dance training should be devoted to strength and conditioning for injury prevention? There's no one right answer for this. I hope you enjoyed my brief insights into hypermobile dancers and look forward to any questions you may have later. And look forward to welcoming Jason Lamb to talk.
Thanks, Anita.
Thanks so much. It's been a great panel, but it has been a long time sitting down. So if you feel like you need to get up and have a jiggle, that would be fine, and feel free to do that. Also, I recognize we are running late, and you're probably looking forward to Anu's talk much more than mine. So we're going to do this kind of like gladiator. So if you're sick of me, give us a thumbs down. She'll shoot me. I'll get off the stage. Okay, so feel free to keep standing or whatever. So my name's Jason. I'm a GP and sports doctor. I think I am obliged to say I'm a senior registrar of the Australian Sport and Exercise Physicians College. So I work with dancers. I work extensively in this space. So I was a professional dancer before I did this medicine palaver, collapsed a lung, went into medicine, so blah. Cool, so I'm here to try and talk about hypermobility in elite and sub-elite sort of sport. And I guess part of the tricky thing is by the time you kind of get to that level, the whole kind of survivorship bias and kind of attrition, most of those people have all the good parts of it. They have tremendous facility, but they often don't have a lot of the downsides. They may still have some challenges to deal with and kind of some modifications, but by and large, they can get away with it. And obviously there's certain sports, the aesthetic sports, dance, swimmers particularly with their arms, it's really advantageous to have that kind of hypermobility sort of thing. One of the things that I guess we should be aware of, particularly if we're in the care team of them, is people who are hypermobile, and as I'm sure we've talked about and people have experienced, you kind of go fine and then something happens, so COVID or an injury or something like that, and that can kind of bring the whole kind of thing down. And I have seen, unfortunately, some people's careers cut short because of that. I don't know what we can really do to prevent that, but just being aware of that and trying to, scaffold them as best as possible so that they don't get that injury, they don't get the major thing which kind of causes everything to collapse. As always, you want, and we've talked about, we really want a great team. This is not a great team. So very attractive, but fairly dysfunctional. So yeah, we absolutely don't want, the God King kind of thinking that they can run everything their way. So it's much more with this sort of model. And I know for those who are pedants that the Bohr model is incorrect, but a probability cloud just doesn't quite work as well. So the idea is you've got your athlete, your artist at the center of it, and you want some sort of primary care member. I'm biased because I'm a GP, so that's why I've stuck myself in there. And you want the coach or the teacher. And as we've all come across, everyone is completely unique. It depends. So what are your particular things that you're great at? What do you struggle with? And that's how we facilitate a team, and we bring in the expertise as we need. And kind of as we've talked about, this is one of the things that we find really tricky, is that people get too excited when you come across someone who's hypermobile. Teachers get excited, like, oh my God, you can do the thing. We're going to do the thing more because that's going to win prizes in the Stedfords and whatever. And kids love it, of course. Why wouldn't you want to be the star of the show? And so that's always the challenge and the risk in trying to temper everyone's enthusiasm for that, and that this is not necessarily good for the athlete. And as Nu said in her talk, it's, and I will always reiterate, you're a person first. Athlete, artist, second, third, that's later. And I love that thing you said, which was, can I steal it? So, no one session will make you, but one session can break you. And so that idea of this can absolutely end your career. It's not going to make it. And one of the things, like my personal bugbears, is particularly in the dance sort of world, no one is a principal before early 20s. Like, why are we doing this to 9 and 10-year-olds? Like, it's nuts. So yeah, overtraining, overloading, and we're definitely seeing this. I've got 9, 10-year-olds who have already been pulled out of school and they're doing 30 hours plus a week of training. And so, yeah, we really want to consider the young person as a person first, athlete, artist, secondary, third. We really don't want to see burnout in our young people. Sport and physical activity is so important for mental health, for health overall. So that should not come at the risk of, who cares about the ride at Stedford? Like, no one's going to care. You've got to live your life, yeah? And so there's quite a bit of work on kind of healthy sort of ideas of sports specialization. And so kind of like the rough guidance in kind of the early years before you get into like where you start to specialize is roughly the number of your age in years as hours of training. So if you're 10, somewhere around the 10 hours is probably reasonable. And if we're talking about, hypermobiles have particular challenges as well. And so that 10 hours shouldn't probably all be in skill acquisition. We need to be doing your strengthening and conditioning and whatever your particular challenges sort of are. And so when I was working with the Australian Ballet, so we try and match the conditioning for the dancer, but also to the repertoire. If we know we're going to do something which is really like jumpy, quad heavy, we're going to spend a lot more time on that. If the boys are going to be doing a lot of lifting, then we're going to try and build that up so that they can make that season. And then you've also got that idea of when do you do this? So you don't want to wear them out by smashing their quads before they do their skill acquisition. So just trying to think about when do you play this in within the context of their work week, managing fatigue and all that sort of stuff. A really important thing which is not exclusive to hypermobile, but all young athletes that I'm super passionate about, is this idea of relative energy deficiency in sport. And it used to be called the female athlete triad. We know that it's more than 3, and it doesn't only affect female athletes. And it's just something to be aware of. And one of the things that I have seen is that, I've got patients who come in with POTS. Actually, this is driving it. They do have POTS, but POTS is a syndrome. It doesn't actually tell you why it's happening. And sometimes it's this. And we fix that, no longer have POTS. So just to keep that kind of in mind, that's a challenge. And then kind of as we get into more elite sports, we start having more and more supplements. As we know with hypermobiles, we have supplements. There's different medications often to manage the comorbidities. And as you go into more elite things, then you start having to being drug tested. And so just being very aware of that requirement. So things like beta blockers and midodrine and stimulants, they can all be restricted depending on what sport or activity that you're doing. And so I always get my athletes to hop on global Dro so they can check whatever they're taking is batch tested and of quality. So I was just going to quickly bang through, haven't been shot yet. So look, there's always questions about what's the correct thing for, how do you manage an injury? Do you do prolo? Do you do massage? Do you use autologous blood? There's so many things you could possibly do. It gets really confusing. And probably the thing to keep in mind is you want to use the right treatment for the particular injury. Yeah? You don't want to under Goldilocks principle. You don't want to do too much. Don't want to do too little. So you want to be precise. You want to target it to exactly what that person needs at that time. One of the big questions is like, should you use steroids? Well, I can't say yes or no because sometimes that is absolutely the right thing to use, but sometimes it's not. So yeah. So it's something to do. That's why you need a care team which understands you and your context. I guess, for example, if you've got an acute inflammatory thing and you've got a championship next week, well, that might be worth it for a steroid because that's the thing that's going to get you to that as quick as possible, and you're going to retire, and this is the thing. Sure, that might be worth it. We know that there's some risks with it. Could be worth it. If it's a grumbling chronic thing, well, probably not. So yeah, it's just something to discuss with your care team so that it's the right thing for you. And probably the other thing to keep in mind is post-retirement. So that's me a very long time ago. As we've all found out, we are often held together by grit and hard work. We retire, we start enjoying burgers, and then it can all kind of fall to pieces. So it's something to counsel your elite athletes as they come out of it, that you can't entirely drop the ball because it can all go to pot. And then probably one other thing to consider is for people who have the capacity to give birth, to have a think about that earlier on in their career, because that might be, if you're retiring in your mid-30s, can be a bit tricky. So it's just something to keep in mind. Anyway, so I think that's me, and I'll pass on to Anu.
Dying to do that. The whole time I was so excited to do that, but it was such a good speech, so I couldn't interrupt. All right, so I've got the graveyard shift. We're at minus 24 seconds, so we're on. But I think we've actually, having a quick look through some of the questions, we've already answered some of them as we've gone through because we're just overachievers. So I'll go relatively quickly through and we'll still have time for questions at the end. So as some of you may know, my name is Anu Francis and I'm a Paralympic triathlete living with hypermobile Ehlers-Danlos syndrome. I'm going to go very quickly through my sporting career because I did speak about this last night at the gala dinner and I don't want to send everyone off to sleep. So this is my elevator pitch of my career. So I started my journey in para badminton and para rowing, but struggled a lot with EDS-related injuries due to the high-impact nature of badminton and then that constant hinging that comes with rowing and just doing the same repetitive movement all day, every day. With EDS not being a classifiable impairment for parasport, I actually ended up being classified on the basis of some neurological symptoms that I had, which was misdiagnosed initially as cerebral palsy, but has since been diagnosed as dopa-responsive dystonia, which is probably linked to EDS, as we heard a bit about yesterday. It is a 1 in a million condition, but there is a crazy high prevalence of people with this 1 in a million condition who also have EDS, which is shouldn't be happening if you do the maths. So in 2020, I talent transferred into triathlon and made my international debut in July of 2022. At the Paralympic level, we raced across a sprint distance, which is a 750-metre swim, a 20-kilometre bike ride, followed by a 5-kilometre run. Since then, I've become the current 3-time Oceania champion. I've received 2 medals at World Championships. I got gold in the 2024 World Triathlon Paris Series Devonport and also won the Paris Paralympic Test event. Thank you. Based on these performances, I qualified for my first Paralympics, which was the Paris Paralympics with a world ranking of world number 2. And I made my debut last year and became the 1,144th Australian to ever represent our country at the Paralympics. Thank you. Unfortunately, after always finishing up on the podium, I came 4th because I flared my backup classic EDS a few days out trying to build my bike. It's always the little things. And so I was pretty disappointed, but have really now, as you'll hear from the rest of my story, have really turned that around and I'm trying to use that, that platform to be able to hopefully do better in the next games, but also to use that for good and to help our EDS community. So, if you weren't here last night, you might be wondering, was my childhood dream to be a Paralympian? It actually wasn't. So my entire childhood, I wanted to be a vet. I wasn't diagnosed with EDS until the age of 21, despite my official symptoms starting at 11, but realistically we can trace pain back to when I started primary school and had to start sitting on the floor. A lot of medical gaslighting came, the classic, what we've heard, the growing pains, being called a hypochondriac, being asked if my mum was abusing me for all these dislocations that were coming up from waking up in the morning. I've got essentially the whole range of spectrum of symptoms, all of the classic EDS stuff. And because of all of that, when I finally got my diagnosis at 21, I told the university, literally could do everything, was getting amazing feedback, amazing grades, and all I was asking for was, hey, could I not stand up for 4 hours when we do a surgical prac, because my body doesn't do that. And instead of being met with that support, I was actually told, well, no, you're not going to meet the inherent requirements to become a vet. And later on, I started studying inclusive education and faced the exact same issue 3 years into my degree. So I now have 2 undergrad degrees in veterinary medicine and education that I can't use, which is fantastic. So because of this, really, I got into parasport. I was looking for other people with disabilities, looking for that community, which luckily I found. And that's led me into a complete career change into coaching, strength and conditioning coaching, as well as triathlon coaching. I've just completed my exercise science degree, and next year, I'm starting the Masters of Clinical Exercise Physiology, really hoping to use exercise as medicine, specialising in hypermobility. So essentially, why exercise physiology? I was very lucky in that when I came to triathlon, my coach just happened to be an exercise physiologist, and we made this amazing relationship where he actually, for the first time, taught me to work with my body rather than against it. When I was in rowing, I had coaches who didn't know about hypermobility, didn't know about EDS, and they were just pushing me so hard that I was just constantly injured. I hated my body. I resented my EDS. It was like me battling the EDS. Whereas coming into working with an EP, he's really taught me that essentially that I am a person before an athlete, as we've already said, which has just been so beneficial. I came in with all these constant injuries, like regular dislocations, subluxations, pain, couldn't walk very far, like I used a wheelchair, like most of the time back then. I'd go to training and then wouldn't be able to walk the rest of the day. I was terrified of a lot of movements, as I'm sure a lot of you can relate to. So really we came in with the primary goals of what our amazing panel has already spoken about: increasing my muscle strength, getting that neuromuscular control, building endurance to compensate for the stability that my tendons and ligaments essentially aren't able to do. The key way that we actually did this was to build that foundation first of all in the gym and then apply that to sport. I think that's the most important parts of that. Yeah. Essentially, I think really what sport's done is it's allowed me to focus on what my body can do rather than what it can't. I think before I was in such of that kind of deficit mindset of the medical, the whole medical theory of this is what you can't do, this is what you can't do. And really my exercise physiology has just showed me what I can do and to focus on that. So I'm going to start off by going through my 3 main challenges that I've faced as an athlete and how we have sort of tried to overcome them. The first one, of course, joint instability. The main management for this has definitely been based in the gym. It's been working with my exercise physiologist to build that, do the baseline testing, do the fundamental movement competence, muscular strength into endurance, and I actually had no range of motion in my shoulders. When I was playing badminton, I would play here because I was so unstable that I physically couldn't reach up and my muscles had all locked up to try and protect the joints. So actually, ironically, we had to actually work on increasing my range of motion and then building strength through that range of motion to prevent the subluxations and dislocations. The special considerations that we used were starting with a really small range of motion. So instead of doing a full squat down to the ground, we would go just down to a box, just 90 degrees, or we can even go up higher than that, literally just do a little quarter squat. Really build up that stability, that neuromuscular control first, and then increase that out through the range. As we've already said, starting light with conservative loads is so important. I used a lot of cable machines and bands earlier rather than free weights, just because it gives you that, that feedback of working in that plane, and you've just got a bit more support than if you're actually trying to control your joints while also underweight. Allowing ample recovery and periodization, so really making sure that there's a lot of different principles, but essentially it is just that pacing and working up really, really slowly. It's, if this is your capacity here, we want to just expand you by this little bit. We don't want you to go and do this big boom bust cycle, because really you're going to be so much better if we can just gradually get you up to that level, rather than you come in and, like we've said, you get really excited and you go, oh, I'm feeling great today, and then you go up and do this, and the next day you crash, and then you're out for 2 weeks or plus more. Having that constant consistency is so much better than that boom bust cycle, and will keep you on that upward trajectory and also minimize your injury risk, which is what we want. One thing I missed on there is that those exercises, they're not sexy. It's like you walk into the gym and you see these big buff guys and you're like, yeah, I want to do that. It's just not what we're aiming for. You're going to be doing a lot of those really not sexy, like lying on the floor with a band, like doing this, doing those really small movements. Not sexy, very effective, long-term sexy. Let's go with that, right? Second challenge for me was that reduced load tolerance and increased recovery time. This led to initially quite poor adaptation and performance, a lot of pain, fatigue, frequent injuries. Again, this is all the same principles that we've gone over to before. A big one that I want to stress is that quality over quantity. I'd rather, in an exercise, if you can do 3 reps with great technique, I'd rather you do that than do 30 reps. You're going to get a lot more out of it. It's going to really reduce that injury risk. Again, consistency focus over that boom bust. This is where we're going to go through our manual therapy, all of our physios, osteos, whoever you use, massage, recovery aids that we've already gone through, really using your different mobility devices, taping, whatever helps you really work with your professionals to help you with that. I think the biggest thing that I found here was the issues with having a condition that affects your whole body is, you might go, oh, my legs are really sore from training, I'm going to use a wheelchair, but then maybe your upper body can't actually handle that, or you're trying to use crutches, but then that's then causing a shoulder issue, and it's so hard to be juggling all those things. So I think it's really, working with probably OTs as well to find what works best for you on any given day. Changing up variety is great. Finally, finding the right team has been so hard. I think we talked about multidisciplinary, interdisciplinary ideally. Mine is definitely still multi at the moment. People don't communicate. It's very hard. I feel like I'm project managing 1 million people. Often disjointed, but really self-advocating, self-education. Find your person. Like we said yesterday, it might end up being, like for me, it's ended up with being an exercise physiologist that's kind of been that person that's helping through, but for you it might be a GP, a physio, whoever. So, as now a triathlon coach, I work with quite a few hypermobile athletes, just out of the blue. So really the key principles, again, this is what I work through. Then going into the swim. So a big thing with the swim considerations is that it's an open chain movement. And so you really want to be focusing on building up that trunk stability to protect especially your lumbar spine. Building that shoulder stability through the swim range with a lot of cable and band work is really helpful. Being mindful of rib mobility. I've picked up quite a lot of costochondritis because my ribs have ended up too stiff. Initially limiting the use of pull buoys, paddles and bands just to reduce putting too much load on those shoulders. Being aware of hyperextension. I know that one of my knees is just, no matter what we do, particularly problematic, so I actually wear a brace that just stops my kneecap from moving around too much, stop me from hyperextending. Being cautious of wall pushes in particular, you can easily hyperextend that lower back, and also if you've got any POTS issues, they're like, can be a bit And then moving into open water swim safety, I recommend if you've got any of those probably don't go in the open water by yourself for safety. Always go out with a friend, make sure they know what's going on. And then when you're swimming in a pool, just being careful not to hit other swimmers as they're coming past. That's quite an easy way to lose a shoulder. Being careful of hitting the lane ropes, just keeping mindful of where you are. Onto the bike. I really recommend, if you can, getting a physio bike fit, including looking at your cleat position. But if you don't have access to one of them, a bike fitter that is trained in hypermobility, or even there are some great apps now that will just look at your different joint ranges of motion and make sure that none of them are going into that hyperextension. This has really been key for me to then use that to build the strength through that range of motion, and then maybe you can go into a more aggressive position if that's what you're looking for, but ideally none of you would be in that middle position because it's not great. But that's when we say that professionals get overexcited. That's when I go into a sports institute and they go, we've got there's no restrictions on what we can do with bike position for triathlon. There's no rules like there are in cycling. And they go, you're super hypermobile. Let's just have you lying flat on the bike, which is not good for your body. And you can't hold that position for 40 minutes without passing out from personal experience. And then saddle selection is also really important with our skin fragility. You end up with a lot of saddle sores. I've had a lot of skin splitting as well. So it's quite important to really go through that process, use your anti-chafes, all of that. Protect your skin, look after it. Get medical advice when you do get them. Adaptive technology, such as thicker bar tape to reduce the impact of the vibrations. I've actually got arm rests that will actually cup my elbows just to take a bit of the pressure off my shoulders. And then things like automatic gears, like DI2, ETAP, and hydraulic brakes can just make it a bit, reduce the impact on your fingers trying to change gears and trying to brake. Finally, the run. As a lot of you will expect, with a lot of people being told they shouldn't run with EDS, it is the biggest injury risk due to the high impact nature. So you've really got to build that strength and that fundamental movement first. Pro tips here, getting a good shoe fit, getting a gait analysis done. I still run on a really low volume, so low load, so like low volume and intensity. Compared to everyone else that I race up against, I'm at a much lower load, but that is just what we've learned is what's necessary with EDS essentially. It's frustrating, but I also do a lot of anti-gravity sessions, so I've got this lever treadmill system that just means that I can still get the run fitness, but without having the impact on my joints. And then the final thing to look out for is like pressure sores, skin breakdown, things like chafing. I've struggled a lot wearing like my AFOs, like having that plastic rubbing against me. The running has just been the bane of our existence. So really just keeping an eye on them, make sure you've got good monitoring. Final takeaways, pretty much always warm up, cool down, prioritise recovery. It's always going to be more important for us than for the general population. Using the traffic light system for pain, that awareness but not catastrophising. One session won't make you, but it could break you. Consistency is key. Some days will be better than others. Just set your goals accordingly, reassess. If you use something like heart rate variability, just check in every morning with how you're going. Keep that variety. Focus on what your body can do. Find your team. I think exercise has literally been the best medicine for me living with EDS as well as dystonia. It's been properly life-changing. So yeah, go out there, find your team and be zebra strong.
Oh, great. Okay, great. So thank you, everyone. That was amazing. We have gone over time, but I think we have answered a lot of the questions already. So what I'll do is oh, of course it's disappeared. I'll read out a question. I won't necessarily get everyone to answer it, but whoever wants to answer, just let me know. So the first one is the doozy we get all the time. How do you do graded exercise when you have comorbid ME/CFS where it is contraindicated? So I thought we might start with Jason. Have you got any opinion about that?
Sorry, can you say that?
So how do you do graded exercise when you have ME/CFS, when the guidelines for ME/CFS say that graded exercise is contraindicated?
So that gets a little nuanced in that the guidelines are like you don't do graded exercise therapy as a treatment for ME/CFS. And that's kind of its own kind of thing. You can still do exercise, but you obviously have to be very careful with that. And honestly, I don't, because I'm not that good at it. I have amazing colleagues. So having an exercise physiologist or usually exercise physiologist, but sometimes physiotherapists can really help with how do you build your capacity without putting you into flare, without going into the boom bust. And that sort of thing. So does that kind of help? It is a total buck pass, but yeah, it's a...
Okay, so maybe I'll take it as well. I think that, you know, the literature for ME/CSF is over here and the HEADS EDS researchers over here, but the overlap is going to be somewhere in the middle. And it's difficult for us as therapists to start pulling away what is actually fatigue, that's EDS fatigue, and is it the same as the ME/CFS fatigue? So what I would suggest is graded exercise to me is getting a program that says you're going to walk 10 minutes a day, and then the next day you're going to walk 11 minutes, and the next day you're going to walk 12 minutes. It's not really giving the full gamut of what you need to do to deal with your problems. So I think there's a lot of exercise you can do that is lying down, and that is also lying down and paced. And also the other thing I often recommend for people like with terrible fatigue is rather than thinking of it as exercise, looking at how you move functionally so that each time you do move, you're sort of strengthening your muscles as you go. So for example, how do you get out of a chair? And are you using your butt muscles to do that, or are you not? When you walk to the bathroom, maybe you could come back by sidestepping down the hallway instead of going forwards, because then you're working your ability to transfer weight in a sideways direction. So if we can look at the things that you normally do and make them different, then we're going to be starting to get some capacity there. Anyone else?
I was just going to say, also there's possibly a lot of things we can do from the ME/CFS point of view, kind of medically as well. So kind of optimizing everything around you can help with capacity, so that you can do the prescribed sort of exercise. But yeah, I guess the big key is tailoring it. So it's not a blanket approach. It's not this kind of like treadmill. It's like, you start here, you finish there, and it's going to take you X amount of time. It's taking into account your circumstances, your capacity. How does your body respond to stuff?
Anita, did you want to comment?
Yeah, and just taking into account that everybody starts at a different point, and it can be really helpful to do an activity diary. So to chart your pain and fatigue levels both during exercise and afterwards, because that's going to give you a good idea of how long you take to recover so that you can plan for next time. So if you've done too much, then the next time you might have to pull back a little bit. Or if you think, actually, I had the ability to do a bit more that time, then you can then work and build that up a little bit more. So it's very much individualized and depends on how much sleep the person's had, what their nutrition's been like, what their stress levels are like. So if you take into account all of those factors, then you're more likely to be successful with gradually progressing your exercise as an individual with ME/CFS. Yeah.
So I've got a question for down this end, which is, does exercising as a young child affect your HEDS in later life? Or how does it affect EDS in later life, I suppose?
I think we can all agree that exercise is good, and as long as you do it slowly and slowly increase your capacity for it. And I think if you're set up with the right techniques and things, and I think even core stability, if you're taught as a young child, and I even start with 12-month, 2-year-olds, are they squatting down to play? Because that's building up their pelvic stabilisers. And they're things people don't look for. So if you start off using these muscles as a child, it becomes more automatic. So it's going to be easier as an adult to use these muscles, and it becomes automatic rather than you having to learn as an adult, I've never used that muscle before and I've got to think about it all the time.
So what about the other side of the coin, the downside? So if there's been a lot of load as a child, say in dance or in gymnastics, can that make the EDS worse later in life? Maria, do you have a comment about that?
Yeah, I think to start with the first sort of flip side that you were alluding to was what we see in clinic is usually if someone's been active and then they stop being active because of COVID or because they've left high school and they've aged out of a dance studio, and then they go through this sedentary period, that's where a lot of things happen. A lot of joint dislocations happen, deconditioning happens, and they then lose the strength that they used to have, and then it's really, really hard to get out of that hole again. So I think to answer the first question, exercise is good because it is physical, it's a form of physical activity, but it needs to be done well. So coming to the side of, can it be detrimental if you overload? Definitely. As with any body that's overloaded, not just an EDS body, you do face the risk of injury with overloading your tissues. So I think definitely there is a downside to that, but it needs to be nuanced. As you said, it's not black and white. You can't not do exercise, but you can also overdo it. So getting yourself a really good sort of healthcare team to manage and to help to coach you through all of those things can be very important.
So Jason, thank you, Maria. Jason, do you ever suggest, because we know how important exercise is for EDS, do you ever recommend to parents to not do a particular exercise in the individual circumstances?
Yeah, so again, it's super individual. So the point that it all depends. So there are some people who are so fundamentally unstable that there are probably certain activities and that those activities are known to be inflexible. So things like classical ballet, gymnastics, depends on the club and the teacher and all that, but on the whole, they tend to be quite inflexible with stuff. So I do vividly remember I've got one patient, you just have to look at her and she'll sublux something. And so, in ballet, you're like this, and that is all there is no other option. There should be. I'm not saying that's the right thing, but unfortunately, a lot of schools, that's the expectation. And from the kids' point of view, that's easy. It's super easy for them to do. It's not good for them, easy. And so you get into this problem of being pushed, and then you get the injury, and then you can get problems later on. Like if you rip your MPFL, if you give yourself a rotten great osteochondral defect because you're constantly dislocating something, that does going to have impact later on in life. So it's about, absolutely, I want people to exercise, but it's finding the right, and it's that balance of finding the right sort of thing for them, which is not going to put them at risk of injury and causing problems later in life.
Excellent.
And I think that it's how you exercise as well. I mean, there's a lot of hypermobile people who like to flick to end of range and lock into end of range when they're doing things. And I think, and people often say to me, oh, should I be not going into that range? And there's some nice research that says that you've got to learn that control at neutral. So initially, no, don't push that range, but then you've got to learn to control that hyperextended range because you're naturally going to use it anyway. So again, it comes back to control. Don't lock at end of range, but learn that slow control through range.
Okay, so we've just got time for one more really quick question, and this one's come in from the therapists. And they were looking at how can we help engage patients that are quite resistant to exercise and want to rely more on the manual therapy or massage side instead of the exercise side. So I suppose I'm looking for a quick 30-second from everyone about how they approach that with their experience. Anu?
Yeah, I think, first of all, explaining the benefits of why you're looking to do exercise, maybe giving them some literature if they're that sort of person that responds to that. I think the main thing is finding exercise that they're going to enjoy. And obviously if they're very against that, then maybe that is that they do it with you and you can be, just chatting through, chatting about their week, keeping them busy while they're doing it so they're not really thinking about it. Or maybe it's hooking them up with some other people and they maybe are going out for a walk with a friend, doing some exercise with a friend, and there's something rewarding like a coffee after that they really look forward to.
Okay, Anita?
So from my experience, and I do tell my clients, I don't tell them, I encourage them, that for people with EDS, the best thing that we can do is stay as strong and as fit as we can for the rest of our lives. And the people that really take on that message and embody that, they are the ones who are at the higher level of function and quality of life. And it's about having an internal locus of control versus an external locus of control. If somebody is taking on the responsibility to take on that themselves, they will generally be a lot happier and healthier. Whereas if they're relying on other people to fix them, then they're always going to be disappointed.
Thanks. Yeah, pretty similar sort of thing I usually tell them. Most people resonate with this, is they go to their manual therapist and they get the massage and they feel great and they come out and then about a day later everything feels horrible again, and that's that whole seesaw thing. You've taken away all this tension and support, and so that feels really nice, but now your joints are trying to fall, your head's trying to fall off your neck, your shoulders are trying to fall out, so you're in pain again. And so all you're doing is really making your manual therapist very wealthy. So, and so maybe we can try and shift that balance. I'm not against manual therapy, it's that balance, so that you get some relief, but we want to try and give you the capacity so you don't need it as often. And then as you get that more capacity, you're not going to be tight and tense and sore, so you're going to need it less, so you're going to overall feel better, and everyone's happy. Except the massage therapists who can no longer afford their Porsche, so yeah.
Did you have anything to add quickly?
What was the question again?
That's no. Okay. All right. So that's
I was just going to say,
yes.
It's especially like working with kids, the parents want them to do stuff. I can't get the kids to do anything. You've got to find what the kids enjoy doing. And especially in summer and things, we're lucky in Queensland, a lot of people have pools and things. They're playing in the pool all the time. So you just give them a few quick little things. Okay, you've got to do so many laps, then you can play.
Yeah.
And sort of try and incorporate it into what they enjoy doing.
I mean, I've got kids that won't do anything I say or exercise, so I certainly understand the frustration. But if you're patient, they come around eventually. That's my thing. Okay, so we're going to have to wrap it up there today. Just wanted to thank all the members of the panel. I hope you enjoyed and learnt something from our panel today. I'm proud of what we produced. I just also wanted to say that I want to do a quick photo after the movement break for any Not Just Spendy staff, clients, carers, referrers, supporters up on the stage, because I just really want to get us all together for a quick photo, if you don't mind. Okay, so thanks everybody.